Good morning or afternoon, depending on where you are. Welcome to the AIM Center's quarterly webinar. Today, we are going to be talking about optimizing collaborative care metrics for program sustainment and giving you examples from the field along the way. I want to welcome you. My name is Monica Harrison. I am with the AIM Center. I'm one of the clinical trainer and implementation practice coaches. Also joined today by my AIM Center colleague, Christy Malmstrom, who is one of the program operations specialists here at the AIM Center. The AIM Center, for those of you not as familiar, helps to support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. The purpose of the AIM Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded, and we'll be sending out a link to the recording and the whole slide deck to everyone who's registered. The webinar format accommodates our very large audience today. So you'll see on your Zoom screen that there is a Q&A function. We're asking you to use that instead of the chat box to enter any of your questions. You can enter those questions at any time for our presenters, but we'll only be answering those questions after all our presenters are concluded. If there's some simple questions, those may get answered along the day. And we'd like you to focus your questions on the experiences of the expert presenters that we have today. If you have general questions about implementation or financing, because there's so much to talk about with collaborative care, we encourage you to please bring those to our implementation or financing office hours. You can also check the FAQs on our website, and that link would be put in the chat for you soon, or probably now. So at the end of the session today, participants should be able to identify essential metrics and key performance indicators to measure the success and progress of collaborative care programs, explore strategies for integrating real-time data into clinical workflows and decision-making processes, understand common barriers to effective data use in collaborative care and how to overcome them to ensure your program is successful, and to discover how to create a culture of ongoing improvement by using data to drive evidence-based practices and refine collaborative care approaches. So today's presenters that we have for you, we have Diane Powers with the University of Washington AIM Center, Brandon Kite, Brandon, hopefully I got that right, but I know you'll correct me if I didn't, from Emory Healthcare, Nicole Kennard from UNC Health, Amy Prentice from UNC Health, and David Thomas from UNC Health. So we are going to kick things off first with Diane Powers from the AIM Center to set some background for us.
All right, welcome everyone, and good morning. So I'm going to talk a little bit about metrics and very specific metrics that healthcare organizations may want to consider. There's no expectation that you would choose all of these metrics. We're going to go through quite a few, and they are going to be tied to these principles of collaborative care. But just to give you some options of things that you might want to consider, this slide shows the 5 principles of collaborative care, and I'm going to show metrics that are associated with each of these principles. You might want to pick one from each of the principles, but if that's too overwhelming, just start with, 1 or 2. And get started with that, and then you can always expand. And I think it'll be really interesting today to hear from our colleagues who have been down this road and who, what their process was for selecting metrics. So, just to really quickly recap, for those of you who might not know, these are the 5 principles of collaborative care. So, that is a patient centered team, population based care, measurement based treatment to target, evidence based treatments, and accountable care. And you can find more information about these principles on the AIMS Center website. And Christy can put a link to that if you want to learn more about the principles of collaborative care. Next slide. Okay, great. So we're just going to dive right in now. And the first principle is population based care. Suggested targets for these metrics are shown in the right-hand column. So the leftmost column, and this will be true on all of the slides that I'm going to use, the collaborative care principle is shown in the leftmost column. Then the next column shows, what is it that you might want to evaluate? And then the third column is, what that metric might look like, how you would calculate it. And then the furthest right-hand column, like I said, are suggested targets. Sometimes these targets are based on published evidence, and sometimes they're based on our 20 plus years of collaborative care experience, helping diverse healthcare organizations all around the country implement collaborative care, and doing also our own studies on collaborative care and what we've seen as something that seems like a reasonable target. So, as part of developing a collaborative care program vision, the healthcare organization identifies their focus population. And one of the things that they may want to measure is how well they're reaching that population with screening so they can identify who needs care and get them enrolled in treatment. For health equity purposes, it's a good idea to look at this and the other data that we'll talk about by race, ethnicity, language, age, other health equity markers. Although that's called out for a couple of the metrics, it's really an overarching analysis that could be part of your metrics monitoring to help you measure your progress toward health equity goals. The second thing healthcare organizations may want to measure is access, how long it takes between a positive screen and the initial assessment. Similarly, they may want to measure time from initial assessment to first follow-up. We know from the published literature that patients are more likely to improve when their first follow-up is within 4 weeks or 30 days of their initial assessment. You should be shooting for a shorter time frame than that, but at the maximum, you'd want to be looking at, what proportion of your patients are having to wait longer than that, because that really does impact, their outcomes. Next, it's a good idea to track the proportion of eligible patients who enroll in collaborative care. There are a number of studies that report on this for programs that serve diverse patient populations. The average that's reported is about 50%, though cost share issues can drive this up or down. So depending on what the cost share is based on the patient's payer, that can certainly drive up enrollment. Programs that do case finding through electronic means only, so maybe using your electronic health record to identify patients with an algorithm that might look at things like prior diagnosis, medications that are being prescribed, things like that, rather than screening and referral from the primary care office, typically have much lower enrollment and engagement rates. So if you do that method of case finding, you just might want to be aware that you're likely to get significantly lower enrollment and engagement rates. It can also be helpful to measure caseload reach. So there should be both a front door to the collaborative care program as well as a back door. Patients should not be kept on the caseload indefinitely, which is why relapse prevention is so important and why a good registry helps identify patients who may be ready for relapse prevention. It can be hard for a behavioral health care manager to let go of patients they like and with whom they've made a great connection. But there are other patients who also need help, and staffing resources are not infinite, or at least none of the organizations I've ever worked with have infinite staffing resources. So it's really important to be looking at, are patients moving through the caseload? Collaborative care is focused on an episode of care. It's not ongoing, indefinite, open-ended treatment. So you want to be looking at, or you want to consider looking at something that measures that. And then finally, looking at frequency of contact can also be really helpful. The behavioral health care manager should strive to have at least one contact per month with their patients at a bare minimum, more frequently when symptoms are more acute. And there are some analyses that have come out that show that there is a relationship between the number of contacts that a patient has early on in treatment and how quickly they get better and how much they improve. So that's something to look at. Many organizations strive for two contacts per month until the patient has a relapse prevention plan, when the frequency can drop to once a month until their episode of care ends. Next slide. Okay, so the second principle is measurement-based care. Measuring the proportion of contacts that include a symptom measure can get left behind when developing a metrics dashboard. It's easy to assume that they are being done regularly, but sometimes we see a gap between expectations and actuality. And sometimes one of the things that we find when organizations contact us and ask us to help come in and diagnose what's happening with a program that's not actually functioning or performing at the level that they had hoped that it would, one of the things that we find is that, they may not be measuring symptoms frequently enough to be able to do measurement-based treatment to target. So sometimes we hear from behavioral health care managers that patients don't want to fill out the measures repeatedly. But in our experience, if the behavioral health care manager helps the patient understand that these symptom measures are kind of equivalent to having your blood pressure taken if you're being treated for hypertension, and that they can help patients get better faster by helping the team know when the treatment should be adjusted, patients are usually willing to do them. It can also be the case sometimes that the behavioral health care manager themselves may not feel comfortable with a quantitative measure as part of treatment. So many behavioral health care managers are not trained to use these kinds of symptom rating scales in their original training programs, and it can be a challenging adjustment for some. You can't do treatment to target if you don't have measures or if the measures are out of date. So this is a really important metric to consider having in your metrics dashboard. Next slide, please. Okay, these metrics also relate to the measurement-based care principle. Quickly identifying when treatment needs to be adjusted is one of the cornerstones of collaborative care. Metrics are essential in helping the treatment plan or helping the treatment team accomplish this. So one of the most important components of any collaborative care program is the systematic caseload review. These meetings should happen weekly, even in the beginning when the program is getting started. And when things are slower at the beginning is when the psychiatric consultant and the behavioral health care manager can develop their working relationship. The behavioral health care manager will learn what information the psychiatric consultant needs to make their recommendations. And being consistent with the frequency and the timing of those meetings instead of ad hoc is absolutely essential for program health. Initially, there'll be plenty of time to talk about all the patients because the caseload will be low. It's important for the psychiatric consultant and the behavioral health care manager to kind of get their rhythm down in those early days so that as the caseload grows, they can talk about 6 to 10 patients per hour. That requires the behavioral health care manager to be prepared with a succinct summary of the information the psychiatric consultant needs to make meaningful recommendations to the primary care provider and the behavioral health care manager. As the caseload grows, it will be important to be efficient and to have a registry that helps you quickly identify the highest priority patients for case review. To accomplish that, the registry should keep track of the length of time since the last case review and whether the patient is at least 50% improved since baseline. When the caseload is full, it's tough to quickly prioritize patients without a tool like the registry to help with those calculations. And then lastly, the most important metric is patient clinical outcomes. You want to know what proportion of patients engaged in treatment have experienced response or remission, and whether this is meeting expectations or not. It can be helpful to keep track of this not only for your current active caseload, but also the historical data from patients who've already been through the program, so you can see what the trend looks like over time. Is it getting higher or lower? And I'll say that, if you only have the ability to sort of start with one metric, this should be the one that you start with, patient clinical outcomes. Is the program actually getting patients better as expected? Next slide, please. So patient experience is one of the elements of the quintuple aim. Increased satisfaction with care has been shown with collaborative care. And as I mentioned earlier, patients receiving collaborative care, who receive those frequent contacts, are also more likely to be satisfied with care. And patients receiving collaborative care in general are significantly more satisfied with their depression care or with their behavioral health care. And there was a paper that was done early on that looked at patient experience, and there are other papers that have been done along with that. So you should be considering at least whether or not you can do that. And you can do that with a lot of healthcare organizations have surveys that they send patients. They have a lot of the larger organizations have contracts with survey organizations who send satisfaction surveys out to patients after they've had some sort of a healthcare encounter. And you can work with them to see if they can add in questions about the collaborative care program, and if they can also add the behavioral health care manager as one of the providers whose encounters trigger one of those kinds of surveys. Okay, so the fourth principle is evidence-based treatments. This is perhaps one of the more challenging metrics to track, but it can be important, especially if the behavioral health care managers that you have are accustomed to providing sort of longer term or open-ended therapy. And even though they may be trained in evidence-based techniques, it can sometimes be easy to engage in sort of more general supportive counseling rather than using a proven technique. It can be challenging to track this because the mode of treatment may be embedded within a text note in the EHR. But if healthcare organizations can track this, it can be helpful. And there's actually a very recent paper that just came out that looks at what are some of the most impactful components of collaborative care. And evidence-based treatments, evidence-based behavioral treatments specifically, were one of the two components that were found to be statistically significant in increasing patient clinical outcomes. So this is something that you really should care about. Next slide. So the fifth principle is accountable care. And accountability, people sometimes make the mistake in thinking that accountability is all about money, and it isn't. From a healthcare organization's perspective, it's how well do processes and outcomes, the metrics that you are tracking for process and outcomes, how well do those align with your vision, goals, and expectations for your collaborative care program? If you are a payer, are you achieving expected cost savings? The data is a little bit mixed on that, but there are definitely studies that have shown clear cost savings in categories other than behavioral health care. So in the original impact trial, they found cost savings across all four categories: inpatient medical, outpatient medical, inpatient behavioral health, outpatient behavioral health, as well as pharmacy. And so, that's something that, you might want to be looking at in terms of metrics. I think that's it for me. And I'm going to turn this over now to the folks at Emory to talk about how they've been handling this.
Thank you very much, Diane. So, first of all, I just want to state that I absolutely agree 100% that everything that Diane just said. And in fact, a lot of the metrics that we use at Emory Healthcare are all based upon or adapted from metrics from the University of Washington Ames Center. We certainly use a lot of those metrics as our initial benchmarks before we were able to identify internal benchmarks. And so, as Monica mentioned, I am Dr. Brandon Kate. I'm the Director of Behavioral Health Integration for Emory Healthcare. So not only am I a psychiatric consultant, but I'm also a healthcare administrator. So I'll be talking a little bit about how we use metrics from that lens. And here is just an overview of the resources that we've developed as part of the Integrated Behavioral Health Program at Emory Healthcare. So Emory Healthcare is a large, diffuse healthcare network distributed throughout Georgia. We service over 350,000 attributed lives, probably somewhere closer to 500 to 600,000 aligned lives across our larger practice. We sit over 11 hospital systems. We have a lot of patients, especially in our primary care service lines, but our Department of Psychiatry is unfortunately infinitely small compared to the number of potential referrals. And so part of my charge has been to develop programs that can improve not only access for patients, but also the quality of care that patients are receiving within care contexts other than the primary care setting. So some of these resources will be familiar, and obviously we're here to talk about the collaborative care model. So we started our collaborative care model in 2021. We are now covering about 40,000 unique primary care patients. We've serviced over 3,500 patients to date. We also participated in some clinical trials where we implemented new screening assessments. We did over 50,000 screeners for opioid use disorder as part of this clinical trial participation. And we've also gone to the extent of implementing other kinds of service lines. So for example, interprofessional e-consultation facilitated through our electronic medical record system. And the other thing we've done is we're taking innovative approaches to interact with our patients in between office visits to do things like improve the number of caring contacts and also, as apropos to the discussion today, improve our opportunities to capture data from our patients and to improve the continuity of data that we get from our patients within our healthcare ecosystem. And that has included a project where we are partnering with a company called Neuroflow, who are a digital mental health technology company who have a patient-facing app and integrating their app and their ecosystem into our EHR. And so at any point along this curve from a referral all the way to a patient needing to see us at specialty services vis-a-vis any of our integrated behavioral health programs, these are opportunities with which we need to capture metrics to, one, understand how we're doing, two, understand how we're operating and whether we're being effective, and three, also as from a healthcare administrator approach, understand what levers do I need to pull in order to optimize things as we progress forward. So going to the next slide. This is just an overview of our collaborative care model at Emory Healthcare. It should look pretty familiar to all of you who are in the collaborative care world and have done collaborative care services. But if you're unfamiliar, starting from left to right, this is the flow of a patient through our collaborative care program. So this represents any primary care clinic that has collaborative care at Emory Healthcare. Patients come through our service line and are identified through whole population-based screening, as Diane mentioned. Patients who meet our minimum screening criteria of a PHQ-9 or a GAD-7 score greater than or equal to 10 are considered for our collaborative care services. They're introduced to our care manager, either via warm handoff or through a referral work queue, which we can track. So that way we are able to know how many referrals are incoming from our primary care providers, even if they're conducted via a warm handoff. And then if a patient is deemed appropriate for our program, we start a cycle of care, which for us on average is anywhere between 3 and 15 months. As Diane mentioned, we don't want patients sitting on our caseloads forever. Collaborative care is very much a model of population-based approaches, greatest good for the greatest many. And so at any given point in time, we like a third of our patients to be fresh and new, a third of our patients to be in the thick of treatment, and a third of our patients to be graduating. And graduation can either mean graduating to a higher level of care or graduating back to the primary care provider's generic caseload. And so you'll notice we don't use the term discharge because technically our patients aren't discharged or going anywhere. They're just moving to a different part of our landscape or our ecosystem. And here what I've also pointed out are, again, different opportunities where metrics are gathered. So here I've called out treatment to target or measurement-based care in the circle or the cycle of collaborative care. That circle represents a month. Just typically because that's when our caseloads are being reviewed, and also that's what the billing cycle looks like for our collaborative care model. So much of the churn and much of the sustainability is predicated on understanding what your cycle of monthly billing looks like. So again, calling out another area of metrics that warrant further, monitoring and a way to capture. And then here I've also pointed out areas where NeuroFlow, for example, is going to fit into our ecosystem. And the next iteration of our digital mental health augmentation pilot, primary care providers are going to be inviting patients onto the platform at the point where they refer a patient to collaborative care. So this gives patients an opportunity for a very low intensity solution that they can use in between their office visits. We're also using NeuroFlow to help capture PHQ-9 assessments, GAD-7 assessments, as well as to deliver psychoeducation content in collaboration with the care manager. And one of our key performance indicators for whether we will continue to work with NeuroFlow is, for example, how does it improve our continuity of our data? How does it improve, for example, caseload volumes? Does it give us more opportunities to bill for minutes in reviewing for NeuroFlow related activities or data? How does it overall impact our service line? And just a quick call out, we can also use NeuroFlow as a step down opportunity. So patients can continue to use the application as part of their relapse prevention plan. And if there's a notable rising risk, for example, the ecosystem will let us know that a patient is getting worse and that we might need to bring a patient either back into collaborative care or send them on to specialty services. Next slide. And so how do we use data within our Emory Healthcare Integrated Behavioral Health Program? And I've lumped it into 4 major buckets. The big ones are, first and foremost, how do we use data towards clinical decision-making and care quality? That's kind of using data for the boots on the ground. And when I'm thinking about data for and metrics for these different perspectives, I'm oftentimes thinking about who is the stakeholder? Who does the data need to speak to? And clinical decision-making and care quality needs to speak to MAs who are doing the population-based screening, the primary care providers who are interested in, one, how their patients are doing, what they need to do next for their patients. And they're also interested in productivity because we incentivize primary care providers based on their referrals into the collaborative care program. Our care managers naturally need to understand how they're doing so we can benchmark their progress. And the psychiatric consultant needs data to make real-time clinical decisions, oftentimes for patients that they're not even seeing. Anything that I've highlighted in green are things I want to call out that are the key performance indicators, KPIs, that we're building into what we're calling a behavioral healthcare manager scorecard. And so as part of our program, in order to help trend internal quality and also to give the care managers an opportunity to understand what their care looks like, we're providing them scorecards that will be reviewed quarterly with them. And again, will be part of their process in driving incentivization and overall productivity. Here are some data examples. Again, a lot of these are the things that Diane already pointed out, but screening fidelity, referral to intake time, what percent of patients who are referred to our program actually make it onto our active caseload, so the conversion rate, what percentage of patients have at least one patient-rated outcome per month in the last 60 days, how many patients have had a case review and when was the last time they had a case review, how long does it take for medication changes to occur on the PCP side from the point where, for example, a psychiatric consultant makes a recommendation. And we also look very closely at things like caseload demographics and payer mix to make sure that the program is sufficiently providing enough equity of care. Knowing your data sources is also critically important. And so a lot of these data metrics are predicated purely based off of what comes out of the EMR. We've developed a reporting infrastructure that's based off of our EMR's reporting workbench, which we use as our registry. Patient quality, as Diane mentioned, we partner Emory Healthcare with Press Ganey, and so we've developed our own custom quality survey asking patients about their experience in collaborative care that is based on some evidence-based surveys that were out there. And we also conduct provider focus groups because we want to know, what do the PCPs see is working or not working with their collaborative care program? Because in doing this work, if you've seen one collaborative care program, you've seen one collaborative care program. Even within Emory Healthcare, each collaborative care program nested within its own respective clinic has different nuances that require some different modifications to best serve that patient population. Next slide. And then the data that I use from a healthcare administrator really looks at things like operations and sustainability. So the stakeholders here are program directors, both clinical program directors like myself, as well as on-site supervisors and administrators, patient financial services who are helping us capture and make sure that the revenue that we're charging out for comes in the form of actual reimbursement. And of course, health system leadership, because they have different taskmasters, they have different things that they're interested in. For example, Emory Healthcare is looking to expand their value-based contracting agreements. And as part of that, they're really looking at the potential impact of improving behavioral health outcomes and especially integrated care to support those efforts. And these are the metrics, again, that are part of our behavioral health care manager scorecard KPIs, as well as the things that I'm looking at pretty routinely. So things like scheduled utilization, no-show rates, the percentage of patients with at least 2 subsequent follow-ups. As I mentioned in the previous slide, understanding our referral to intake conversion rate, and how our work RVUs are being optimized. Because at the end of the day, we need to be bringing enough revenue in order to be sustainable. At the very least, cost neutral, cover the costs of the program. And so we need to learn based on things like our known payer mix, who's coming into the program, and who's being on our service. Are we going to be able to generate enough quote unquote billable events in order to cover our costs? And this allows you to, again, pull levers like understanding FTE allocation, understanding your revenue flow. And also, really what I'm looking at is where are the opportunities for scaling and for growth? Because at the end of the day, I have 4 practices amongst over 40 practices in the primary care ecosystem that I would love to expand to. But given that we just started out in 2021, we really needed to prove our worth. And these metrics are the things that our health system is really looking at to understand what the real ROI or return on investment is of implementing the collaborative care model. The data sources for a lot of this are external to our EMR, although they're very much influenced by our EMR because that is our sort of true north data set. And we've created some external data dashboards with some data analysts in order to do that, as well as working with our patient financial services folks. Next slide. Some of the challenges and lessons that I've learned so far in this role, both as a psychiatric consultant and a healthcare administrator, on the side of data capture and fidelity, it's really important to understand your EMR workflows and to optimize them as much as possible so that it's easy and as seamless as possible to capture data from our patients. Understanding that patient-driven data capture through self-assessment can sometimes not be the best, but it sometimes can be more efficient. So thinking about, what is going to help save time but not degrade quality is critically important. If your care managers are spending the majority of their time just capturing metrics, that's not also an efficient use of their time because they don't have a lot of opportunities to engage much more in the treatment elements or aspects of their behavioral health care manager role. And as I kind of alluded to is, how can we leverage things that scale really, really well in this space to help improve efficiency? And so that's like leveraging things like technology, your EHR, ways to communicate with your patients in order to capture information in a way that's timely and efficient. And then on the other side of things is data use and interpretation. So in this role, it was really helpful for me to be an Epic super user on our EHR to know where data lives and how and who has access to it, because I can very quickly point people in the right direction to make the process of developing our dashboards really efficient. That can be really challenging depending on where you sit in your health system, but I have found that to be incredibly advantageous. And so if you're not the person who has that understanding, it really behooves you to find the person who does have that understanding and work closely with them. Constructing scorecards and dashboards are really, really important, but understand that not everybody needs all of the data. And so thinking through, what is the right data for the right person at the right time? And again, thinking through who is my stakeholder and what change might I be trying to institute on these individuals. And lastly, make sure that you showcase your data early and often to the stakeholders and showcase the data that matters. So for example, my behavioral healthcare managers and my PCPs are much more interested in clinical outcomes, less so on overall revenue outcomes, ROI outcomes, whereas a lot of my health leadership partners, while they're interested in the clinical outcomes, they're much more interested on the bottom line, sustainability, return on investment, other things that are much more important to them. And so thinking about how you can use metrics and data to help influence your system, influence the reach of your program are things that I would really want to highlight. Next slide. And this we actually don't need to really belabor, but this just gives you an idea about what our collaborative care program looks like in terms of staffing, in terms of numbers. I develop these clinic dashboards or scorecards just to understand what the demographic is and the population is from both the provider perspective as well as the patient population perspective. And this is also critically important when you're thinking about where to go next, or maybe even if you haven't done collaborative care, where do I go first? So data and metrics that were really helpful were looking at who in my health system amongst primary care providers are already doing a lot of primary care-based mental health services. Who has the highest PHQ-9 and GAD-7 capture rates? Who, for example, is billing a lot of ICD F codes for psychiatric services? And that can really help you think through who might be good behavioral health care, collaborative care champions from the primary care perspective, and understand like where you should go within your health system. And so with that, I will close and I will try to field any questions that might be coming up in the chat. I will hand off to my colleagues at UNC. Thank you.
Thanks, Dr. Kite. I'm really feeling grateful and fortunate to be here. My name is Nikki Kanar. I'm an LTSW, and I help to operationally and clinically lead our collaborative care program at UNC. So you can go to the next slide. So it's my job to sort of lay the foundation. I'm here with my colleagues, David and Amy, both of whom have been really instrumental and fundamental in both developing collaborative care, but also metric tracking. But I want to sort of set the stage on the journey to collaborative care for you all before they jump in with more metric detail. So we started with behavioral health integration. Not we, Amy and her team started with behavioral health integration at UNC back in 2017 in some select academic family medicine clinics. And then later, almost just as soon as collaborative care codes were available, began billing and implementing that program in 2019. Later at that time, their team expanded from 1 LCSW to 2, and just increasing that FTE over the year. Then in 2022, additional TOCM services were launched in community primary care clinics, and then also an academic internal medicine clinic and a geriatric clinic. At that time, we had 2 LCSWs that were dedicating their entire FTE to 8 clinics. We still had a face-to-face model, still also doing virtual services in the way of phone calls and virtual services, but primarily we're in the clinics still too. And then later in 2023, between 2022 and 2024, we launched a bit of a shift in the way of referral and scheduling systems, highlighting a centralized pathway. So that's when we kind of shifted a bit more to receiving and providing services in a virtual department, not just specific to those dedicated clinics. Then we arrived in September of 2024, and we did our biggest expansion yet, where we expanded to 57 additional primary care sites within that centralized workflow, and covered academic and community primary care clinics, piloting a split FTE model. What that meant is our folks were providing both brief treatment services embedded into primary care clinics on some of their days, and then on other days doing just the collaborative care model centralized. We added at that point an additional 1.5 FTE split across those 4 LCSWs. And again, as already mentioned, created even more of that centralized team to enroll and provide services for all patients. I'm going to kick it to Amy next. She's going to talk about metric tracking from the start, and then later David will finish off sharing a little bit more about what it looks like now.
Thank you, Nikki. So when we first launched BHI back in 2017, we were building our program from the ground up. We recognized that there was a need for a comprehensive system to be able to track our patients, and we created a custom registry in Excel. That allowed us to start manually inputting and tracking our referrals and adding patients as we enrolled them into the program. Drawing on the framework provided by AIMS, we identified key patient level and program level metrics and outcomes that we wanted to track, and we began with just a small focused set of data points to incorporate them into our Excel registry. This approach provided us with the flexibility to add new metrics and outcomes as they were identified and prioritized by our team. I then used pivot tables and charts to create an Excel dashboard that allowed us to really monitor our KPIs. And this dashboard became an essential tool for sharing our program level outcomes, particularly as we began advocating for the expansion of our team. Over time, the reporting and analytics capabilities have advanced significantly, and I'll now hand it over to my colleague David to share more about what he's done to help build out our new Tableau dashboard.
Thank you, Amy. So at the UNC Health Alliance, what we have worked, we partner with our wonderful information services department, who have created a data warehouse where they extract data from our EHR systems and pair it with some relevant demographic data that we're able to join in with it, and they refresh that daily for us so that we can have readily available metrics that are accessible through tools like Tableau, which is what we use to create our dashboards across the system. And so in 2022, we first created this dashboard. It honestly matched a lot of what Amy made, but alleviated a lot of the manual inputs that were required at the time. And ever since we've created it, we viewed it as a living document. It's something that routinely receives improvements that are based upon ways that we can find opportunities, but also make sure that we're consistently mirroring the processes that the LCSWs are following on the ground level. Next slide, please. And so in this dashboard, we've really tried our best to view this system or view this process as a system, and to make sure that we have a really clear sight into each aspect of that. So we have the referrals captured, where we can see when and how patients are being referred, and our success in converting those into appointments and making sure that they're seen. Gives us the ability to make sure that when inappropriate referrals are placed, that we're able to educate those locations that have placed them, and also just to make sure that we have a clear line of sight into our incoming volume so that we can scale the program appropriately. Then paired with that, we have a view of enrollment, minutes that we track for the patients that are enrolled, and then the panel size for our providers that are caring for those patients. Each of these views really look at the same information, but make sure that we're framing it in a way that's relevant to what people are trying to answer the question for. You know, enrollment summary is us looking at what's the total, what is the overall enrollment in the program at any point in time? Is it growing? Is it shrinking? We can slice it by location or provider to make sure that we can observe these overall trends. For the minutes and panel size, we're able to look down at the care manager LCSW level and make sure that if there are limits in the capacity that they're providing, we can supply them with the resources they need to make sure that patients are receiving the care they need routinely. And then lastly, for billing and patient outcomes, this is where we get to make sure that we're having the effect that we need to have. So for our billing and reimbursement tab, we can have a clear vision of, at each location that we're supporting, what are we generating the reimbursement that we expect? What's the denial rate looks like? What are those reasons for? And for them. And so we can have actionable data as quickly as possible to make sure that we're following up as necessary. And for patient outcomes, we can go to the next slide now. We are tracking depression, remission, and response, as well as anxiety remission and response. And we're visualizing the progress of those over time per patient. And one great thing about what Tableau and the technical solution we've created gives us the ability to do is to not just look at that for month over month, for the patients that graduated now, what are they doing versus the ones that graduate next month. We're able to bring them all together and say, and look at how quickly are patients achieving the outcomes that we're looking for. And again, slice that by the various locations and providers that are supplying those interventions to find those successes so we can amplify those in the future. And you can go to the next slide. And so looking forward, we've really done a lot of work to try and make sure that we're able to track those outcomes and provide consistent care. But the next level is to take those demographic dimensions that our ISD has given us the ability to connect to and look across the dimensions of age, race, ethnicity, preferred language, potentially others, to try and find more opportunities to provide effective care and to to take any measure from the dashboard and see how those outcomes look proportionally to the enrollment in the program. That's it for me.
Yeah, and I'll just add, thank you, David. I think for us at UNC, what Amy and David have created allows us to now not only continue to dive into the value of clinical outcomes and tracking clinical outcomes, which are really important, but it also helps us to root ourselves in fidelity of program models as we expand. We're providing collaborative care across the state, and we want to ensure that at each effort to optimize or to shift to meet the need of our patients and our providers, that our program metrics remain strong and solid, and our metric and tracking allows us to do both of those things. So that's it from our team. Monica and Christy, thanks for having us.
Yeah, absolutely. Thanks, everyone. It's always enlightening to me to hear what everyone is actually doing out in the field, the things that align, and the new innovative things that people are coming up with. So I'm always glad when you all are willing to hop on and share that with the group. Always very good, valuable information to hear. So it is time for our questions, our Q&A questions. So we have some questions that were submitted. I know we won't get to all of them. That is just the way the world turns with timing. Some of the questions in the Q&A are around finance as well as implementation. So I again encourage individuals to please join the AIM Center finance office hours, and we also have separate implementation office hours to ask your questions, not only of the AIM Center team, but also to hear from your colleagues around the world who are implementing collaborative care. So I want to focus today specifically on some of the questions that had to do with measurement. So one of the things that came up in the question, and I'm wondering if Emory and UNC, you guys are able to chime in, and then Diane as well, what you've seen out in the field for tools that you use, or how are you measuring patient satisfaction as well as your provider satisfaction. So anyone who wants to start first, just in terms of how you're measuring that, are you measuring that, or have you considered it, and what have you seen out there?
I can answer or
Yeah.
sure. And I've been trying to noodle and answer some questions in the chat. So, but yeah, so overall, we developed our own patient satisfaction survey, just to and we're really covering a couple of things. One, we wanted to capture who are our patient, and also to capture information like, was this your first engagement ever with collaborative care or mental health treatment at all? So we really wanted to understand from the patient perspective, like what their access or what accesses look like for them historically, what their perception of the problem that we're solving with them is. And then we asked them essentially four groups of questions. One is what has there been their experience with the behavioral health care manager? Everything from how easy is it to schedule with them to they're helpful with my problem, they understand my problem. What is their understanding of the role of the primary care physician? Do they feel like the patient feels like the primary care physician is more involved in their care, less or so? They know what the treatment plan is. And then their understanding of the role of the psychiatric consultant, who's sort of like, the man behind the curtain. And then lastly, just what has been their overall experience, and we capture some free association from them. Interestingly, most of the patients, just to give you some ideas, find the program incredibly valuable. The free text data we capture are generally around issues around billing. Either the program is quote unquote too expensive or whatever, but that oftentimes is something that often comes up, is the cost of treatment. Granted, a lot of patients don't have an anchoring for what the cost of behavioral health treatment might look like in the community, for example. So that's been kind of an interesting finding. And then lastly, we ask about, how likely are they to refer our program or to refer programs like it. And that's based off of surveys that are readily available in the literature, and we just adapted them for our program. With respect to our providers, we do, again, focus groups, and it's an iterative process. We get a baseline number of assessments around, like, how comfortable are you managing mental health treatment, mental health problems in your clinic? What have been some barriers in working with patients? What has the referral process looked like? And then we do an iterative approach where we ask them similar questions, open-ended questions about their experience with collaborative care. How has it impacted their practice? Do they think it's better, worse, or neutral for their patients, et cetera, et cetera? So a lot of it is really just working on good mixed methods, qualitative implementation kinds of research approaches, and capturing those questions. And sometimes I'll bring data to the table. So for example, I can see who amongst our practice is a high referrer to the program and who might be a low referrer to the program, and ask them questions that are uniquely suited to a better understanding what their experience is as to why do they refer or why do they not refer.
Thanks for that,
Very
Brandon.
similar.
I was getting ready to
Oh,
say
go ahead, Monica.
I saw some head nods from the
Mhm.
UNC team. I was kicking it over to you guys. What say you
Yeah,
on
cool.
your, yeah.
Yeah, I was just going to say, especially to what Dr. Kate just said related to engagement, I think we primarily lean into referral data and understand who is referring and who isn't. We often also pair that up to eligibility data. So if we know that clinics have high eligibility rates within their patients of folks that would benefit from COCM but are also not referring, then we typically make more of an effort to get out and to be with them in their space and to educate on the services. And for patient engagement, curious what Amy and David have to say, but I think also there we're using the data of billed minutes to speak the story. If patients are engaging in the service, we're considering them engaged. But Amy and David, jump in if I left anything out.
I absolutely agree. I'm intrigued by the Press Ganey survey involvement, and I think that's been sort of a limited option for us across the board. But I think that's a really interesting way to get more objective feedback from patients that we can track over time.
I will also mention, if people are interested, we set up a very complex system to do it based off of billing. So that way we don't oversample patients, but essentially we automated it so that way we know the first month of billable services, and then we count 3 months later. If they haven't had a bill, we send a survey. If they have been getting repeated services, we don't send them a survey out for about 6 months. So we're capturing assessments either every 3 months if they're lost to follow up, or every 6 months if they're actually engaged in the program. I will tell you also that the response rates, when you do it in this manner, is typically pretty low. I think industry standard for primary care is sometimes as low as like 1 to 2%. We've gotten actually up on some months up to 10 or 15% response rates, but it gives you enough data to understand sort of what's going on. I will say with patient quality surveys, when you're doing them in that manner, you have to take some of them with a grain of salt, because patients who are most likely to respond are most likely to respond about negative things. And so it can also skew you to think there's a lot wrong with your program. So you kind of have to be a little bit careful about how you interpret some of that information. But it has been really valuable to understand the things that, when they are a problem, what are going to be the biggest problems. And when they provide really nice data, it's excellent and very reinforcing to feed that back to your PCPs and your care managers, because they oftentimes don't get that self-reflection of the care that they're providing. So very valuable for our program.
Gotcha. Diane, I saw you came off of mute earlier. I just want to make sure I didn't miss your voice.
Yeah, that's okay. I was just gonna say, what Brandon just said,
Okay.
in terms of, that you're, the bias toward negative responses, we all get surveys and, if everything was fine, a lot of times people just chuck those in the recycle. But if something didn't go well, they're gonna be more likely to, want to fill that out. So you do have to keep that in mind.
Gotcha. Does anyone have specific inclusion or exclusion criteria that they are using as they're looking at, as you're looking at your data and all of the metrics? Like, are there certain ICD-10 codes that you're excluding? Is there something in clinical history? Does anyone have anything like that when you are assessing and creating your metrics that you include or exclude?
For our program specifically, we typically or historically have excluded severe and persistent mental illness and primary substance use as the reason for referral. We tend to connect those patients to a higher level of care or more intensive level of care, though sometimes we do enroll them as a bridge because there are often long waits to get into mental health, behavioral health providers across the country and also specifically in North Carolina. And so just looking at sort of acuity and knowing because we have such a finite amount of resources and a huge pot of patients that are potentially interested and eligible, making sure we get patients to the right level of care as quick as we can to have enough access for all of the patients that we'd like to see in the program.
Gotcha. What about you guys over at Emory, Brandon?
Sorry, I missed the beginning of the question. It was
If
inclusion and exclusion.
Yeah, whether or not, as you're looking at the data metrics or deciding what you're going to look at, are there any inclusive or excluded criteria that you're looking at, like ICD-10 codes that you exclude or certain clinical history, things like that,
And you're meaning like who we include or exclude from the program from
from
collaborative
the data you're looking at. Yeah.
from the data we're looking at. So yeah, we've left it pretty open, and I use terms like patients who are suffering from symptoms of depression and symptoms of anxiety. We do have a, let's call it structured inclusion exclusion criteria that are suggestions, strong suggestions in terms of minimum severity. So for example, we want symptoms that are greater than or equal to 10, although we are creating care pathways for patients with lower scores that can leverage like BHI codes and some other things, but can dig into that if people are interested. But patients, with severe mental illness, for example. I mean, the major thing I tell my primary care providers when we're starting this program is I'm happy to treat whatever you're happy to treat. Meaning that you have to be comfortable as a primary care physician in prescribing the medications that I'm going to recommend. And if that includes like MAT or Suboxone or buprenorphine, or if that includes an antipsychotic for a patient with chronic psychosis, I'm happy to help you. But really what we look at is, is there a large demographic of those patients in that clinic that demands that for the population? So I think we use metrics bidirectionally. We don't usually use it to necessarily include or exclude patients. We get it to better understand what are the needs of the population and how might we rise to serve that need. And so that's kind of how I think about it. The biggest metric that I would love to capture, just to close that loop, is patients. We don't want patients referred to our program who are currently seeing a counselor or currently have a psychiatrist.
Okay.
We do have a lot of those patients that fall through the crack, and because we have such little bandwidth, most of the patients in our actual primary care clinics, if they are seeing folks, are seeing people outside of Emory Healthcare. And so sometimes the primary care providers will try to kind of squeak patients through to try to get them Emory Healthcare behavioral health access. And we really discourage that because, again, we want to capture people who have no access or have first-time access. And that's a difficult data pain point because there's not great ways to capture that necessarily without asking the patient. And so that's another theme here is, there are a lot of blind spots when it comes to data and metrics, and developing systems to capture good quality data can be really hard.
Gotcha. Yeah. Well, thank you guys. We appreciate you joining us today for the webinar. Of course, those who did not get their questions around implementation and finance answered, please join our office hours. There are some resources here. We will be sending out the PowerPoint so you can go back and reference some of these things. And also to let you know, the quarterly webinar series is something that we do every quarter. It's probably been about a year and a half, I guess now, or maybe 2.5, now that I think about it, that we have been doing this. So please register and join us next time on July 15th, where we will be talking about blended models and so how that works in addressing your patients on a continuum of integrated care. So we'll see you all next time and have a rock star rest of your day.